Institute. Looking forward to a very fruitful session, and I would like to introduce right now Dr. Habib Traif, who really does not need introduction. He is the consultant cardiothoracic and vascular surgeon, head of the cardiothoracic surgery at Mohammed bin Khalifa bin Salman Al Khalifa Cardiac Center in Bahrain. And he is also assistant professor in the Department of Surgery and the Arabian Gulf University College of Medicine and Medical Sciences. Dr. Habib is has an FRCS from Ireland, and he did his higher surgical training certificate in cardiothoracic surgery in June 1987. And he is very well known to the community, not only in Bahrain, but in the region, to be an excellent cardiothoracic surgeon. So I would leave it up with you, Dr. Habib, and I'm looking forward to a very fruitful session. Thank you very much, and wish you success in the presentations. And I'm sure that the number of attendees will be more now. It is 1:32, and looking forward to a successful session. Dr. Habib, you are the leader now.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Qasim, for this nice introduction. Yes, hopefully this evening we'll have a very nice program. And just on behalf of Bahrain Specialist Hospital and Apollo Heart Institute, I would like to thank you very much for organizing this meeting. This evening is an evening of science and healthcare. Cardiac disease, as you know, is the leading cause of health concern worldwide, and developments in prevention pathways as well as treatment are increasing exponentially. Today,
Yeah, you can.
So okay, so we start again. Okay. I thought that as unmute. So thank you very much, Dr. Qasim, for this nice introduction. And as chairman of this session, I would like to thank Bahrain Specialist Hospital and Apollo Heart Institute for organizing this evening. This is an evening of science and healthcare care. As you know, cardiac disease is the leading cause of health concern worldwide, and especially in this area with development in prevention pathways as well as treatment, and increasing this exponentially. Today, we bring together a world-class cardiologists, cardiac surgeons, and healthcare professionals to discuss the latest development in cardiovascular science. And the title of this session, obviously, the management of acute myocardial infarction, both ST elevation and non-ST elevation MI. So in addition to myself to chair this session, I have esteemed panelist, Professor Saeed Al-Saeed, a consultant cardiologist and head of cardiology in the Department of Medicine in Salmania Medical Complex, Dr. Rath, interventional cardiologist and head of Heart Institute at Apollo Hospital, Hyderabad in India. And to moderate this session also, we have Dr. Prashant Prakar, consultant cardiologist at Bahrain Specialist Hospital. So I'm happy to hand over to introduce the first speaker to Dr. Saeed Saeed. Dr. Saeed.
Sir, you have to unmute yourself.
Event, as well as for Dr. Qasim and the organizer of the Bahrain Specialist Apollo Heart Center event. I'm glad to be a part of this, to participate in this event, and I would like to present Dr. Abdulaziz, who is the first speaker. And Dr. Abdulaziz is the interventional cardiologist and director of the Cath Lab at Bahrain Specialist Hospital. He will touch on the management of acute myocardial infarction, recent updates, very, very important topics, changing guidelines. And so please, Dr. Abdulaziz, start your presentation. Thank you very much.
Thank you very much, Dr. Saeed Al-Saeed, and thank you very much, Dr. Habib Tarif, and all the other esteemed panelists for joining this session. We'll begin with the session. This is first talk is about the recent updates in the management of acute myocardial infarction. I would be taking a few questions in the beginning. It's a small poll. If the attendees can please answer. First question is very simple. And so we get to know who all are viewing this with us. So I request all the participants to answer this question. So see a lot of GPs and physicians, a few cardiologists and cardiac surgeons in this. All right. So yes, so as you all know, acute myocardial infarction is a leading cause of death worldwide, responsible for approximately 42% of all deaths from the cardiovascular disease. And a similar situation in Bahrain, where cardiovascular disease is responsible for almost 1 in 5 deaths here. And we all know early and effective intervention is required in order to preserve as much of the cardiac function as possible, improve survival, and reduce the risk of later complications. Now, there have been recent updates on the management of ST elevation MI and non-ST elevation MI, starting from the 2013 ACC guidelines to 2015 focused update. Then there was the 2017 ESC guidelines, and recently 2019 Canadian Cardiovascular Society has given a focused update. So I'll be borrowing heavily from these recommendations. And non-ST elevation MI guidelines have been the 2014 ACC and the 220 ESC guidelines for the management of acute coronary syndromes without ST elevation. Now, as we all know, ECG remains the cornerstone of diagnosis and risk stratification of acute coronary syndromes. And 12-lead ECG recording and interpretation is indicated should be done with a maximum target delay of 10 minutes. So the patient comes to the emergency with acute chest pain within 10 minutes, and ECG should be done and should be recorded. And we we monitor patients' cardiac ECG with the defibrillators as soon as possible in all patients with suspected MI. Now, pain relief is an important feature of acute MI when the patient comes to you. A lot of them are in severe debilitating pain, but pain relief has been dealt with slightly differently in the two different guidelines. The ESC STEMI guidelines, they considered IV opioids, including morphine, to be the drug of choice, and sometimes a mild tranquilizer like benzodiazepine should be considered. But the recent Canadian guidelines have suggested avoidance of routine IV analgesia. I'll come to the reason for this, but selected use of opioid analgesic medication may be considered for severe pain with the goal of relieving pain and reducing anxiety. Now, there were a couple of trials on this. The first one was the Atlantic trial. This was basically done for pre-hospital loading of ticagrelor. And what they found was that in patients who received a pre-hospital ticagrelor and did not receive concomitant morphine, they showed more frequent pre-PCI ST segment resolution compared to those who received morphine. The hypothesis behind this is morphine delays gastric emptying, so the absorption is delayed and may produce nausea and vomiting, which may nullify the effects of oral loading of medicines. There was a large registry called the Crusade registry with 57,000 patients. This was a non-ST elevation MI patients. And in these patients, people who were given clopidogrel with morphine were compared with those without morphine, and they found a higher risk of death among patients who were given morphine. So based on this, the recommendation is to avoid routine IV analgesia, but if the patient is in severe pain, yes, you might have to consider giving it. But as my professors used to say, the best pain relief for acute MI is opening up the artery. So that is what we should try to achieve as soon as possible. And a couple of things about oxygen supplementation. Earlier, there was a practice of giving all patients oxygen, but then now it says only if the saturation levels are less than 90% or less, only then oxygen is indicated. Routine oxygen is given a class 3 indication. And there is some evidence suggesting that hyperoxia may be harmful. This is because of the oxygen radicals, and it may increase myocardial injury. Now, as we all know, in STEMI, when we come to STEMI, time is muscle. The more time we lose, the more muscle is lost, and the worse are the outcomes. So we should try to reduce the time to perfusion, and timely perfusion should be documented. Now, the different reperfusion strategies for STEMI, of course, primary PCI, fibrinolysis, and the pharmacoinvasive strategy, and facilitated PCI. Facilitated PCI is more or less out now. This used to involve giving a dose of thrombolytics immediately before PCI or on the transfer route, and then taken up for PCI. And this was shown to have high bleeding risk and high mortality rates. So coming to fibrinolysis and primary PCI. Now, primary PCI, as you all know, is and should be the modality of treatment for everybody. Fibrinolysis can be given if the patient presents to you early, if a Cath Lab is not available, if there's difficult vascular access, and if the patient will need a prolonged transport more than 60 minutes. And the door-to-needle time for this is less than 30 minutes. Actually, the ESC goes on to say from the STEMI diagnosis, it should be less than 10 minutes if a decision to lyse the patient has been made. Now, primary PCI is the modality of choice, but it becomes mandatory if the patient is in cardiogenic shock, is in pulmonary edema, has ventricular arrhythmias, and if the presentation is late, more than 3 hours, these patients do better. And of course, it is a contraindication to fibrinolysis. And when the strategy is to do primary PCI, then you have to stick to a door-to-balloon time less than 90 minutes. I'll come to that in a while. So fibrinolysis may be suitable for STEMI patients to present early in the course of the infarction, and the greatest benefit is seen in the first 2 to 3 hours after symptom onset. And also, this may be part of a pharmacoinvasive strategy. So as an alternative to primary PCI, the patients are early presenters who have low risk of bleeding and who cannot undergo rapid primary PCI. So recommendations, when fibrinolysis is from the ESC guidelines, when fibrinolysis is a reperfusion strategy, recommended to initiate this treatment as soon as possible after STEMI diagnosis. So if you look at this, so STEMI diagnosis, meaning the ECG reading and interpretation should be done within 10 minutes and another 10 minutes to lyse the patient. So if the strategy is going to be lysis, so 20 minutes, at the most you can extend to 30 minutes. And of course, fibrin specific agents are recommended, tenecteplase, alteplase, retiplase, and half dose tenecteplase may be considered in patients who are more than 75 years of age. Now, what after fibrinolysis? You have lysed the patient, and then what should be done afterwards? Now, several randomized trials. I would like to launch a simple question again here. Now, supposing we have this scenario. We have a scenario of 45-year-old male comes to the emergency room with acute chest pain for the last 3 hours. ECG shows ST elevation in L1, AVL, V1 to V6. Heart rate 104 per minute, blood pressure 110/70, Phillips class 1. What is the best treatment? So is it primary PCI or fibrinolysis or either PCI or lysis? So 45-year-old gentleman, acute chest pain, 3 hours, relatively stable. We're getting a lot of responses. So most of the attendants agree it is primary PCI. A few of them say fibrinolysis. About 1/3 of them say either PCI or lysis can be done. So these are the results. Yeah. So now, what happens after the lysis? So now there were several randomized trials and meta-analysis showing that early routine angiography with subsequent PCI required after fibrinolysis have reduced the rates of reinfarction and recurrent ischemia. The optimal delay has been a matter of discussion, and the earliest has been 1.3 hours in the capital AMI trial to as late as 17 hours in the Garcia and the STREAM trials. Now, the ESAE guidelines say transfer to a PCI capable center following fibrinolysis indicated in all patients immediately after fibrinolysis. And interventions following fibrinolysis, emergency angiography and PCI is required in patients with heart failure or shock. Rescue PCI if fibrinolysis has failed, which means there's less than 50% ST segment resolution at any time in the presence of hemodynamic or electrical instability or worsening ischemia. Angiography and PCI of the infarct-related artery recommended between 2 and 24 hours after successful lysis. And emergency PCI in case of recurrent ischemia or occlusion. So the most important point is even after successful fibrinolysis, which means you've given the patient the drug, his chest pain has come down, the ST segment has resolved by more than 50% at 1 hour, but still you need, the recommendation is to do an angiography and PCI of the infarct-related artery between 2 to 24 hours. And what about transferring the patient for PCI rather than lysing and sending the patient? So transfer of PCI has been shown to be better than lysis alone if done in a timely manner. So these are the various trials that were conducted on this, starting from the Prague 1, Prague 2, and the Dynamic trials. And so this should be the model of reperfusion. Now, patient comes to acute with an acute STEMI at a PCI center. So the STEMI diagnosis should be made less than 10 minutes and then should be taken up for primary PCI with a goal of door to balloon or door to device time less than 90 minutes. If the patient comes to a non-PCI center, make the diagnosis, and then you try to calculate what is going to be the time delay from the first medical contact to the PCI. If we can achieve this within less than 120 minutes, then transfer the patient for PCI with the goal of having a transfer time less than 60 minutes. Or if it's going to take longer than 120 minutes to take up this patient for PCI, the strategy should be fibrinolysis with door to needle time less than 30 minutes. And after this, immediate transfer for failed lysis and routine PCI within 24 hours for successful fibrinolysis. This should be the strategy of revascularizing these patients. Now, primary PCI is the preferred reperfusion strategy in patients with STEMI within 12 hours of symptom onset by an experienced team and should be performed as soon as possible. Now, the earliest evidence came from the Keeley meta-analysis of 7,000 patients where they compared primary PCI versus lytic therapy. And mind you, most of these patients received a fibrin-specific agent and stents were used only in 12 trials. And they found the death rate, the reinfarction rates, the total stroke rates, intracerebral hemorrhage, as well as a combination of death plus reinfarction plus CVA, all were better when the patients underwent primary PCI. Now, there was a recent meta-analysis published in Circulation in 2009. So it's about 23 RCTs and 32 observational studies with a total of 8,000 patients in the randomized control trials and about 185,000 patients in the observational studies. So what they found was primary PCI was associated with reductions in short-term mortality of 34% in the randomized trials and 23% in observational trials. And at long-term follow-up more than 1 year, they found primary PCI was associated with 24% reduction in mortality and a 51% reduction in reinfarction in the RCTs. Now, primary PCI was associated with reductions of stroke as well, about 63% reduction in stroke in the RCTs and 61% in the observational studies. So the recommendation, reperfusion indicated in all patients with symptoms of ischemia of less than 12 hours and persistent STA segment elevation, class 1. Primary PCI strategy recommended over lysis within the indicated timeframes, class 1. If PCI cannot be performed after the diagnosis in a timely fashion, then lytic therapy, if there are no contraindications. Now, what happens to the late presenters? We often see patients who had spent in the night and then come to you the next day. So if the time from symptom onset is more than 12 hours, a primary PCI strategy is still indicated if there is ongoing symptoms of ischemia or hemodynamic instability or life-threatening arrhythmias, a class 1 indication. And a routine primary PCI strategy up to 48 hours from the symptom onset is a class 2A recommendation, so it should be considered. And beyond 48 hours, if the patient is asymptomatic, routine PCI is not indicated. It's the same thing. Now coming to a very important concept, the door to balloon time, or the first medical contact or device time, or also called as a wire crossing time. So this was a study done very early in 2006, where they showed the in-hospital mortality increased with increasing door to balloon time. So as the door to balloon times grew from 1.5 hours to 3 hours, the mortality went up from 4% to 12%. So the target should be less than 90 minutes, and we should strive to achieve this within 60 minutes. To highlight this, I'll show you a recent case. A 49-year-old Indian male, diabetes, positive family history of CAD, retrosternal chest pain for the last 30 minutes. ECG shows ST elevation V1 to V4. A quick bedside echo shows regional wall motion abnormality with anteroseptal hypokinesia, LV of about 45%. So this, we took him for angiography and primary PCI. So these are the images you can see. Total occlusion of the proximal LAD artery. So immediately a wire was passed in, and then we can see some flow has started to trickle into the left anterior descending artery. And this was followed by direct stenting without balloon predilatation. And this was the result. And a very good result is seen. Very well flowing artery with a TIMI3 flow and improved contraction. The patient was discharged after 48 hours. He's come back for follow-up multiple times, and follow-up shows no regional wall motion abnormality. LV function is normal now. Now, the two most important things that were responsible for this is an early presentation. Patient recognized his symptoms because he had a family history. He knew that he was having a heart attack, came to the hospital within 30 minutes, and we were able to reopen the artery within 32 minutes. And so this has given rise to a very good result. Now coming to the route of access for primary PCI, there were a host of trials recently. A rival trial, the rifle STAS trial, the matrix trials, all of these trials have shown that radial access is associated with lower risk of access site bleeding, vascular complications, and need for transfusion. Not just this, there's also a significant mortality benefit in patients allocated to the transradial access site. So the recommendation, radial access recommended over femoral access if performed by an experienced radial operator, the ESC guidelines class 1A recommendation. There was a talk of deferred stenting as well in between. So this was a concept where they said not stenting the patient at the time of the primary PCI reduced microvascular obstruction, because we see sometimes no flow, slow flow phenomenon happening after stenting in the even during a primary PCI. But in the large study, which is the Dynamic 3 defect trial, so in this, they stented the patients 48 hours after the index procedure. So they do the angiography, they put in a wire, they open the flow, then they put the patients on anticoagulants, and then after 48 hours, they come back to do the stenting. So it had no effect on the primary clinical outcome, which is a composite of all-cause mortality, non-fatal MIs, or ischemia-driven revascularization. And there was a higher need for target vessel revascularization. And based on these findings, the routine use of deferred stenting is not recommended. Now about thrombus aspiration, this also has been highlighted recently. Initially, there were a lot of small center studies which showed that there was a benefit from routine manual thrombus aspiration. In fact, all of us used to do this about 5 years back. It was the routine. So whenever we saw a lot of thrombus, we used to aspirate with the aspiration catheter. Then there were a few trials, including the total trial, TASTE trial, and then the large meta-analysis. So the total trial with the combination of about 10,000 patients showed there was no benefit of routine aspiration strategy. And there was an increase in the risk of stroke. And then there was the meta-analysis of combining all the major trials. And in that, they showed when there is high thrombus burden, thrombus aspiration was associated with fewer cardiovascular deaths, 2.5% versus 3.1%. But there were more strokes and TIAs. So there is certainly a risk of stroke or TIA, but then sometimes you might have to do it, but routine aspiration should not be done. So recommendation, routine use of thrombus aspiration, not recommended, the class 3. An example about this patient. So a 32-year-old patient came to us with chest pain since 4 hours. This was an ECG taken at a different center showing huge ST elevation in V1 to V4, a little bit in V5. But for some reason, this patient got delayed. This was, I think, the peak of the corona season. All the ICUs were full, no hospitals were accepting patients. And he came to us almost 4 hours later. And by the time he has come, he's already developed some Q waves and ST depression, T inversion. In the emergency room with us, he had one episode of non-sustained VT. The LV function was 25%. He had hypotension, blood pressure 90/60, and few basal crackles on auscultation. So because he's a very young patient and he was having a VT, and also we decided to take him up for PCI, a delayed PCI, you can call it. So this was the angiography of this patient. I may show you again. So here you can see the LAD artery is totally occluded from the beginning, faint filling into the ostium, but otherwise nothing else afterwards. And this was a wiring. After the wiring, we barely see any flow into this artery. And so as is routinely done, so pushed in a balloon, tried to dilate it with a balloon, and hardly any flow is seen. And then after multiple balloons, this is the picture. So you see a large thrombus burden, which is not responding to the usual methods. So we gave him intracoronary GB2B3A as well, and then there was no benefit of that. And then multiple balloon dilatations, and then you see a little bit of flow coming in. So herein I decided this patient needs thrombus aspiration. So introduce the thrombus aspiration catheter, and then you can see the thrombus aspiration catheter going down well into the distal segment. And immediately after that, you see some flow has started to appear. And this is how aspiration clot looks like. And we were able to retrieve multiple of these in 2 or 3 runs of this aspiration catheter. And after that, he underwent a repeat balloon dilatation. And then now you can see flow is established into the LAD artery. After this, he underwent stenting of the LAD artery. The longest stent is put into the LAD artery. And this was the final result. So you can see a very well deployed stent with TIMI3 flow into the LAD artery. So this patient recovered well, his EF came up to 40%. So this case highlights the need for thrombus aspiration, but it should not be considered a routine. Only if there's a huge thrombus burden, then we should definitely consider this. Another question about doing primary PCI is multivessel revascularization. So we see multivessel disease very commonly in approximately 50% of patients with STEMI. So the question is to do only the culprit or complete revascularization. So the guidelines have changed quite a bit on this. So the 2011 ACC guidelines, they said PCI of non-infarct artery at the time of primary PCI should not be done. Similar guidelines were from the 2012 ESC guidelines. But then there were multiple trials, including the DANAMI3 primary trial and the culprit trial. So these showed that doing the non-culprit artery is safe and it leads to better outcomes. And so the ESC 2017 guidelines, they have said routine revascularization of the non-infarct related artery lesions should be considered in STEMI patients with multivessel disease before hospital discharge. The timing is a little controversial. You can do it either in the same sitting or do it before hospital discharge. But mind you, try to avoid this when the patient is in cardiogenic shock, as we saw in the culprit shock results. So when immediate multivessel PCI was done, the mortality or renal failure requiring dialysis increased from 45% to 55%. To highlight this, another case, a 55-year-old Bahraini gentleman, a known case of hypertension, family history of CAD, diabetes de novo, episodic chest pain for the last 4 days, severe crushing pain for the last 4 hours. Echo on admission showed regional wall motion abnormality, anteroseptal, anterior apical with an EF of 25%. So we took this patient for a primary. So you can see the LAD again totally occluded. There's about a 60 to 70% lesion in the proximal circ as well. And here you see the LAD is not filling at all. What we see is a very tight lesion in this OM, which we'll see in the further views. And the LAD was wired and ballooned and some flow was seen. And you see 2 lesions, one in the distal LAD, one in the proximal LAD. And so the distal LAD and proximal LAD was stented. And after stenting, this is the result. A slightly slow flow, which later on improved. But I want you to focus on this OM here. So this large OM has a very tight critical stenosis. So normally we would try to avoid doing it in the same setting if the patient has low blood pressure, low EF, and a shock. But otherwise, we should try and open such critical lesions. So this artery was also addressed. So this OM was stented, and then a good result was seen into the LAD as well as in the OM. So you can see fairly good result in both the LAD and OM. And this patient has recovered well. His EF now on follow-up is about 40 to 45%. So multi-vessel PCI must be considered in all patients presenting with STEMI. Culprit vessel PCI only if the patient is in shock. If there's a poor result of the culprit PCI, patient has acute kidney injury, cannot tolerate contrast load due to renal insufficiency or LV dysfunction. Chronic total occlusion should not be attempted in the same setting. Complex coronary lesions like a left vein bifurcation, if they are not the culprit, should not be attempted in the same setting. So a flow chart on this. So if there is multi-vessel PCI, patient is hemodynamically stable, so do complete revascularization at the time of PCI or as a staged procedure before discharge. If in cardiogenic shock, do not perform non-culprit lesion PCI during the initial procedure. Now coming to non-ST elevation MI, so these patients come with acute chest discomfort but no ST elevation, and the pathological marker is rise in cardiac enzymes reflective of cardiomyocyte necrosis. So ECG changes may be varied from transient ST segment elevation to depression to T-wave changes, or sometimes the ECG may be normal. Now the important update that has come in the ESC 2020 is about the cardiac biomarkers, the role of high sensitivity cardiac troponins. So measurement of cardiomyocyte biomarkers, preferably the high sensitivity cardiac troponin, is considered mandatory in all patients with suspected ACS. Now, these are more sensitive assays. They increase the diagnostic accuracy for MI at the time of presentation compared with the normal ones. So with this, you have the rapid rule in and rule out algorithms. So when you do a high sensitivity troponin, the time interval to the second cardiac troponin can be shortened when we are using the high sensitivity assays. Recommended to use the 0R 1R algorithm, which is the best option, or the 0R 2R algorithm. I'll show that in a bit. So what has been seen is when in these patients are assigned the rule out, so the negative predictive value is more than 99% and has been validated in large cohorts. And even after the rule out of MI, elective, non-invasive or invasive imaging may be indicated according to the clinical assessment. The positive predictive value for MI in patients meeting the rule-in criteria using high sensitivity troponin is about 70 to 75% patients. And these patients usually require invasive coronary angiography or CMR imaging. Now, so this should be the algorithm. Suspected non-ST elevation ACS. You do the high sensitivity troponins at 0 hour and 1 hour. If the 0 hour is very low or low and there is no increase in the delta high sensitivity troponin value, so you effectively rule out these patients, and these patients can be prepared for a discharge with an option of stress testing or a CT coronary angiography or invasive coronary angiography, depending on the other risk factors. Now, if there is a high risk of initial cardiac troponin or the delta change is high, then you rule in MI and these patients are admitted to CCU. Now, there will be a lot of patients who come under this other category. So these patients need observation, a 3-hour cardiac troponin plus echocardiography, and then the further strategy can be planned. To highlight this, one case, 58-year-old male, not a diabetic, hypertension on irregular treatment, heavy smoker, pain in left shoulder and chest for the last 7 days. Then sudden onset excruciating pain brings him to the emergency room. This was the ECG, fairly normal looking ECG except for a few atrial ectopics here and there, no STT changes. So the first sample we did both a regular troponin and a high sensitivity troponin. The regular troponin was negative. The high sensitivity troponin was 16. Our cutoff is 2. So if we consider more than 5 times the cutoff, then it is definitely positive. We repeated the troponin after 2 hours. The regular troponin was still negative, but the high sensitivity troponin jumped from 16 to 88. So 5 times jump was seen. So we took this patient for angiography, and then what we found, a very tight stenosis in the mid RCA. You can see very tight stenosis, more than 90% stenosis in the mid-RCA. These are the running videos. So you can see a tight stenosis here and here in the mid-right coronary artery. So this patient underwent angioplasty and stenting, and this was the result. So a very good result seen, and then the patient was discharged after 2 days. So coming to this observe category, so patients who do not qualify for rule out or rule in are assigned to observe. So you repeat troponin at 3 hours and do an echocardiography. Invasive angio should be considered if there's a high degree of clinical suspicion. In low to intermediate likelihood, non-invasive imaging should be considered. I'll skip these slides for want of time. So the most important thing when we talk about non-STACS is risk stratification. Depends on ECG findings, biomarkers, and the clinical score. So if there's a high risk score, which involves age, heart rate, systolic blood pressure, creatinine, cardiac arrest at admission, ST segment changes, cardiac enzymes in CLIP class. So we know the probable in-hospital mortality, and patients with high risk score should undergo immediate invasive strategy. Now, these patients are labeled as very high risk patients. They have at least one of the following criteria: hemodynamic instability or cardiogenic shock, recurrent or refractory chest pain despite medical treatment, life-threatening arrhythmias, mechanical complications of MI, heart failure clearly related to non-ST elevation ACS, presence of ST segment depression more than 1 millimeter in more than 6 leads, plus ST segment elevation in AVR or V1 pointing towards the left main or triple vessel disease. So these patients should go on an immediate invasive strategy, which is less than 2 hours. Then the early invasive strategy. So if the patient have a diagnosis of non-ST elevation MI, dynamic or presumably new ST changes, transient ST segment elevation, high grace risk score, this patient should undergo an early invasive strategy, that is within 24 hours. And low risk patients, so if they're troponin negative, no history of diabetes or CKD or CAD, hemodynamically stable patients, no recurrence of angina, these patients are low risk patients. They can undergo appropriate ischemia testing or a CT coronary angiography, and these are labeled as class 1 now. So we'll skip this. The key messages: early diagnosis is the key, use of high sensitivity troponin, rapid rule in and rule out, immediate intervention for high risk patients, early interventions for very high risk patients, early intervention for high risk patients, and stress imaging or CT coronary for stable, lower, intermediate risk patients. Thank you so much all for the patient hearing.
Okay, thank you very much for this elegant speech. So I think it has a lot of information, and I'm sure that there will be many questions at the time of panel discussion. So we'll go for the next talk, and the next talk is by Dr. Amir Ardati. He's going to talk to us about acute myocardial infarction in the COVID era. Dr. Amir is the interventional cardiologist in the University of Illinois in Chicago. He's the director of Cath Lab at Jesse Brown Veterans Administration Hospital, director of Heart Center at University of Illinois, Chicago, and co-chair of the Emergency Cardiac Care Committee at University of Illinois in Chicago. He has been awarded with the Clifford Blitz MD House Staff Award and an overseas fellowship from the International Institute of University of Michigan. Dr. Amir, looking forward to your talk.
Thank you, Dr. Thraif, for the warm welcome. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Honored guests and participants, welcome from Chicago. I want to spend a little bit of time talking to you today about the impact of COVID-19 on heart disease. The agenda for today is we will review the impact of COVID-19 on heart disease. I'd like to share some cases from the front lines and review some mechanisms that we can work together on to improve heart health care during the pandemic. I'll start with the first patient that I saw on the first week of the initial spring surge here in Chicago. This was a 32-year-old woman with morbid obesity with a BMI of 80 who was presenting with fever, cough, and shortness of breath, and was found to have a large pericardial effusion. The ultrasound was very difficult due to the patient's body habitus, but as you can see, she has a large circumferential effusion that was also noted on her CT scan. We took her to the lab emergently with full PPE and placed a drain where we liberated 700 cc's of fluid. The patient improved and managed to be discharged on postoperative day 4 with supportive care. So COVID-19 has sundry and various clinical stages that you may have observed in your clinical practice, but the initial stage that we all recognize is mild constitutional symptoms with fever, dry cough, potentially GI manifestations. And this is followed by a phase of direct lung injury resulting in an ARDS syndrome that is quickly followed by a host inflammatory response phase that is characterized by shock and a hypercoagulable period. And all 3 stages of this condition can impact cardiovascular care and have major cardiovascular complications that I'd like to review with you. Interestingly, from the Chinese experience, we know that myocardial injury, as demonstrated by the presence of a positive troponin, occurred nearly in 1 in 5 patients. And we know that the presence of myocardial injury was associated with worse outcomes. We also know that pre-existing cardiovascular comorbidities in patients with COVID-19 significantly increased the risk of adverse events, particularly mortality, and that those patients with pre-existing cardiovascular disease who also had an elevated troponin were at the very highest risk of mortality, underlying the importance of risk stratifying these patients early on. Here's another patient we took care of. This is a 58-year-old woman who presented with shortness of breath and severe hypoxemia. She was noted to have a troponin of 11. A CTPE in the emergency department showed a large right-sided pulmonary embolism. And as you can see from our invasive pulmonary angiogram, that her right pulmonary artery is essentially occluded with a large thrombus. We used an Inari T24 catheter and performed thrombus aspiration with reestablishment of her right pulmonary artery flow. And you can see in the bottom right the large amount of thrombus that we liberated. This patient was discharged on postoperative day 2 on apixaban and did very, very well. So thrombotic events in COVID-19 are remarkably common, and we think that VTE can be as high as 25% in patients with symptomatic COVID requiring hospitalization. Many autopsy studies have been performed. The 2 that I think are most interesting are one from Ochsner in New Orleans and another one from Germany, both demonstrating a high burden of both micro and macro thrombotic events in these patients, underlying that these patients, there is something about this disease process that promotes a hypercoagulable state, and this hypercoagulable state has important clinical manifestations. The next order question of what level of VTE thromboprophylaxis is necessary remains unanswered, but there is a sense that high intensity thromboprophylaxis in high risk patients is probably warranted before the manifestation of a major complication. So why does myocardial injury occur? As I showed to you earlier, there is an entity of thrombotic events. So certainly microvascular thrombotic events may be occurring in the coronary circulation, but certainly there's an increased propensity of macrovascular thrombotic events, whether they're in the pulmonary artery circulation or the coronary circulation. We know too that the virus directly invades the myocardial tissue, resulting in a viral myocarditis, and that those patients with pre-existing coronary vascular disease may be at risk for type 2 myocardial injury secondary to demand ischemia. And in fact, these manifestations are various, as we discussed. So you may have a true acute coronary syndrome with plaque rupture and thrombosis. There may be the so-called Minoka syndrome, MI, with no observable coronary obstruction that may be due to inflammatory milieu or to stress cardiomyopathy. Arrhythmias are very common, and we'll discuss that briefly in the next few slides. Pericardial effusion, as I showed you earlier, or macrovascular thrombotic events all can lead to myocardial injury during the COVID infection period. Here is a 61-year-old gentleman who presented with shortness of breath and chest pain, whose chest x-ray showed diffuse interstitial findings, and an electrocardiogram that showed anterior ST elevations in the setting of chest pain and hypoxemia. The patient was taken for an emergent diagnostic angiogram where he was found to have a completely normal study. The patient subsequently developed a supraventricular tachycardia with augmentation of those ST segment changes that were seen earlier. However, on hospital day 3, the patient had improved from his COVID pneumonia, and his electrocardiogram reverted to what appears to be normal. Arrhythmia, in addition to thromboembolic events, appears also to be very common in COVID-19. And in fact, nearly 20% of patients admitted have an arrhythmia. And of those patients that reach the ICU, 44% will have an arrhythmia, with serious arrhythmias of VT-VF occurring in as high as 6% of patients. We believe that these events are caused by direct myocardial injury or due to medications that may prolong the QT segment. It is critical to avoid QT prolongation with medications in these patients and to be judicious with the management of electrolytes to avoid the propensity for severe arrhythmias in these vulnerable populations. So what does work in COVID-19? As we can see from how different places have dealt with the pandemic, that certainly the use of population measures to contain the virus are highly effective, and we hope that with the introduction of the vaccine in the coming few weeks, that there will be a further suppression of the pandemic. So prevention strategies with an emphasis on social distancing, hand hygiene, and social measures to take care of income are critical. Hospitals that are equipped with appropriate PPE with an emphasis on protecting staff and resources are important, and the soon-to-be released highly effective vaccinations will make a critical impact. Importantly as well is the critical need for high quality critical care with ARDS best practices and the use of evidence-based interventions such as dexamethasone, which has been shown to improve mortality and morbidity in these patients. And I can't underscore enough the critical importance of nursing, of high quality nursing in managing our hospitals and our patients. So here's our next patient. This is a 68-year-old gentleman with COVID pneumonia who presents with infralateral ST elevations, who was taken urgently to the catheterization lab. And here's his angiogram showing an occlusion of the LAD just distal to the first major septal perforator. The patient was managed with standard therapy, and as you can see, there is a high thrombus burden both at the plaque and in the apical LAD. The patient had recovery of TIMI3 flow with the exception of the distal apical embolism, of the thrombotic embolism. And the patient did clinically well. What was interesting in our experience, and I think has been replicated around the world, is that ST elevation MI activations in our hospital dropped severely during the height of the spring pandemic. This was documented in observational data from both the United States and Italy and the United Kingdom, where where ST elevation MI and non-ST elevation MI presentations in hospitals dropped considerably during the height of the surge. Moreover, this was also observed in Hubei province in Wuhan during the original outbreak. And not only did the reduction in STEMIs occur, but there was also a difference in how patients were managed. So as Dr. Aziz mentioned, the optimal management of an ST elevation MI was with primary percutaneous therapy. However, due to the pandemic, there was a decrease in primary PCI and an increase in thrombolysis. So not only did the virus change the epidemiology of acute coronary syndrome, the virus changed our behavior as a healthcare system, and these changes in behavior directly impacted patient outcomes. So as you can see, with the hazard ratio of thrombolysis increasing, there was an increase in mortality and an increase in heart failure in these patients and a decrease in timely reperfusion, all of which show that our changes in behavior have impacted cardiovascular outcomes in a field that we should have extensive expertise in. So in sum, STEMI presentations are coming late. There are delays in care, and our management of these patients are changing. We need to think about why this is occurring. Well, in this helpful schematic, people have thought a little bit about why STEMI care changed. And at the top line, patients are worried. There is a fear of approaching the healthcare system. Healthcare systems may be overwhelmed, and the ability to present to PCI-capable hospitals may be limited, similar to what Dr. Aziz presented with the late presenting patient that he described. And patients, as they present to PCI-capable hospitals, may not be treated with optimal therapies due to fears or limited staffing ability to manage these patients. All of these reasons have informed this algorithm that was put out by worldwide cardiovascular societies to address how to manage ST elevation in COVID-19. The critical outcome, as you can see at the bottom of this algorithm, is that primary PCI remains the primary method of treating ST elevation, regardless of whether or not the patient has COVID-19. The critical juncture in these patients is understanding whether or not the patient is infectious and whether or not the patient truly does have an infarct, and to make sure that these decisions and considerations are made in a timely manner in order to avoid undue injury to the patient or inappropriate exposure to the team taking care of the condition. I hope that I've described to you that COVID-19 has many cardiovascular manifestations and that the myocardial injury associated with COVID-19 worsens COVID-19 outcomes. I want to underscore the need for COVID-19 therapies to be evidence-based and for us not to give up on good evidence-based therapies like primary PCI. And I believe that hospitals like BSH will continue to offer and expand cardiovascular care during this pandemic, despite the difficult circumstances, and they'll be able to do so by being prepared and being organized. And I thank you, and I'll take your questions at the end of the discussion, and I wish you an early happy National Day from Chicago to you in Bahrain.
Thank you very much, Dr. Amr. Dr. Rath, if you want to introduce Dr. Abdul.
Yeah, it's my pleasure to introduce Dr. Abdul Wahab Muhammad Al Khalifa. He's a consultant cardiac surgeon at Muhammad bin Khalifa bin Salman Al Khalifa Specialist Cardiac Center in Bahrain. He's a very experienced cardiac surgeon, having experience in most of the very, very prominent university from Canada and Europe. He did his residency from Master University in Canada, then pursued 1 year of cardiac surgery fellowship in University of Toronto, and followed by minimal invasive cardiac surgery and fellowship at University of the level in Quebec City. He joined back in Muhammad bin Khalifa Cardiac Center in 2017 as a consultant cardiac surgeon, and his special interest in mitral valve surgery. And he'll be speaking to us about cardiac surgery in acute MI. Dr. Abdullah, please.
Thank you very much, Dr. Prashant, for the introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. So I'll be talking about the role of CABG, coronary artery bypass grafting, in acute myocardial infarction. First of all, I have no disclosures. Next, when we talk about acute myocardial infarction, it's a spectrum. It ranges between non-ST elevation MI, ST elevation MI, cardiogenic shock, and each of these disease processes has a different effect on the heart. The myocardium can be infarcted, which means it's non-viable. It could be stunned, viable but dysfunctional with recovery potential. The myocardium can be hibernating, meaning it's viable myocardium with prompt recovery potential. Cardiogenic shock can result because of severe LV damage, left ventricular damage, severe right ventricular damage, acute myocardial mitral regurgitation, ventricular septal defect, and free wall rupture. The patients who present with acute myocardial infarction can present in different ways. They could be stable patients with symptoms that had regressed, settled down. They could have ongoing symptoms, but still be stable in terms of hemodynamics and in their behavior in the operating room. They could be unstable patients with inotropic support, or require a mechanical circulatory support, or patients who are crashing, whether crashing before going to the operating room or crashing on anesthetic induction. So whenever a patient comes with acute myocardial infarction, usually they present to the hospital, to the emergency room, or get transferred from another hospital like we saw in the previous presentations. So initially they get stabilized, they get loaded with the dual antiplatelet therapy. They might get thrombolysis. Then they go for a coronary angiography, whether emergently or later on. And we, as a cardiac surgery service, get involved when there's a failed PCI or complex anatomy, or someone who needs mechanical circulatory support. And then the decision for coronary artery bypass grafting is made. That decision is made usually based on guidelines that were presented by Dr. Aziz. Once we're in the operating room, we do the coronary bypass grafting. And after that, the patient might have a smooth recovery. They might need inotropic support. They might need intra-aortic balloon pump support or mechanical circulatory support, or they might even die, unfortunately, and sometimes. And then obviously post-op care. So these are the ESC guidelines in 2018. I will not go over them because Dr. Aziz already presented them. But in terms of NSTEMI, there's very high risk, and intermediate risk. He also presented the management and in terms of immediate invasive in the case of very high risk, early invasive in the case of high risk, and invasive strategy within 72 hours in the intermediate risk. The STEMI guidelines have already been presented by Dr. Aziz. So the key thing is the presentation within 12 hours with ST elevation, more than 12 hours, but ongoing ischemia, hemodynamic instability, life-threatening arrhythmias, or ischemic symptoms suggestive of MI plus hemodynamic instability, recurrent ongoing chest pain, life-threatening arrhythmias, mechanical complications, and acute heart failure. So all of these will lead to a primary PCI strategy. Once there is a failed PCI, ongoing ischemia, a large area of myocardium, then we go for CABG. The other end of the spectrum is the cardiogenic shock. So patients with cardiogenic shock usually receive medical therapy, inotropic support, ventilator support, reperfusion and revascularization strategies, and repair of mechanical complications. Mechanical complications include ventricular septal defect, acute mitral regurgitation, free wall rupture, like we described before. Some patients stabilize after this management, and some other patients are unstable. So you would institute short-term mechanical circulatory support. I'm going to show you some of the devices that we use later on in the presentation. Once there is a recovery of cardiac function, we can wean these devices. If there's no recovery of cardiac function, then we assess the neurological status. If it's irreversible, then we have to wean. If it is favorable, then the other devices can be inserted, which are longer term, or the patient can be referred for a cardiac transplantation. So I included a slide on the coronary artery bypass grafting surgery because I knew that I would have a varied audience, and not everyone would have entered into our operating room. So it was very important for me to describe our surgery. And so our surgery is obviously done under induction and general anesthesia. Usually then we would open the chest through a sternotomy and harvest the conduits. The most common conduits are the left internal mammary artery, the saphenous vein, the long saphenous vein. We also use radial arteries sometimes. So as you can see here, this is the ascending aorta, this is the anterior surface of the heart, this is the interventricular groove. You see the LAD, the left anterior descending artery coursing here, the diagonals going here. This is the right atrial appendage. And this is the SVC, and this is the IVC, superior vena cava, inferior vena cava. Now, our prime objective is to restore blood flow to the myocardium. During that time, we need to preserve this myocardium and preserve all the other organs, including the brain and the kidneys and the peripheries. And so to do that, we need to get the blood siphoned from the right atrium to the cardiopulmonary bypass machine, and then back into the body through the cannula going through the ascending aorta. And then our objective is to stop the heart. To stop the heart, we use a cannula here. We put a clamp here to isolate the circulation of the body from the circulation of the heart. We give cold blood cardioplegia, which is very rich in potassium. And so once we do that, the heart will stop because of the high potassium concentration. This will allow us to rest the heart in diastole. And then we can do our anastomoses. You'll see here the left internal mammary going to the left anterior descending artery. You can see a vein graft going to the right coronary system. So once we have done our targets, we start weaning off the cardiopulmonary bypass circuit. And then we decannulate and then close the chest. And the patient goes to the cardiac ICU. Now, because this is data from emergency surgeries, and this shows you the difference between patients who were in cardiogenic shock and patients who were not. And it's divided into NSTEMI and STEMI. So the mortality, in-hospital mortality in these emergency patients, or urgent patients actually, went up to 5.9%. In a pure NSTEMI case, but in cardiogenic shock cases, it goes up to 15%, as opposed to STEMI starts off with 5.3% and then goes up to 23.9% in cardiogenic shock. And that is why we have to optimize outcomes. To optimize outcomes, we have to carefully plan when we are going to do the CABG surgery. This is old data from 2001, which is a landmark study. It was a retrospective study that looked at the mortality in patients who underwent coronary bypass grafting after suffering from a transmural myocardial infarction and a non-transmural myocardial infarction. It's very important to see that the mortality rates in the first 24 hours is very high. And there might be a selection bias here. And that's basically because we were forced, or the surgeons were forced to operate on very high risk patients. But also it reflects the disease process. When the heart is freshly out of a myocardial infarction, then the recovery rates are much less. And so in non-transmural MI, in non-STEMI patients, we try to do the surgery maybe at least 5 days or more, which allows us to, number one, allows the heart to recover from the myocardial infarction. Number two, it allows all the dual antiplatelet therapies to circulate out of the system. Intraoperatively, we can optimize the patient also. And basically, we need to stop the heart. So that would decrease the oxygen consumption. By that, I mean we go on cardiopulmonary bypass, which allows us to rest the heart in diastole. Second, we cool the heart, cool the body, which also decreases oxygen consumption. We can use mechanical circulatory support, and we need to have good hemostasis to prevent bleeding postoperatively. We use the thromboelastography, blood products, hemostatic agents. This is a graph that is showing the effect of whole body temperature against oxygen consumption. You'll notice at 35 degrees Celsius, the consumption of oxygen is around 7 ml per kg per minute. That decreases to around 4 ml per kg per minute at 30 degrees Celsius. On cardiopulmonary bypass, the patient's body temperature slowly drifts down, and we allow it to do that to around 33, 32 degrees Celsius. And that preserves the heart, it preserves the brain, preserves the whole body. The second graph is the effect of the cardiopulmonary bypass on the oxygen consumption. So this is the oxygen consumption of a beating working heart, around 9 ml per 100 gram tissue per minute. You put the patient's heart on cardiopulmonary bypass. Basically, you take out the work of the heart, you reduce that from 9 to around 4.5 ml per 100 gram per minute. Once you stop the heart, so this is a beating heart. You're on cardiopulmonary bypass, but the heart is still beating. Once you give the heart cardioplegia, the potassium-rich solution, you stop the heart in diastole, this 9 ml goes down to 1 ml per 100 gram tissue per minute. The next strategy is using short-term mechanical circulatory support. And basically, the most commonly used is intra-aortic balloon pump. And basically, it's a balloon that is inserted from the femoral artery up to the descending thoracic artery. Now, what is the purpose of this balloon? This balloon gets inflated during diastole, and that's when the coronary circulation gets its blood. So it inflates, pushes blood to the coronary arteries, and then it deflates during systole, creates a suction, and decreases the afterload. Now, the intra-aortic balloon pump is very commonly used. There is a trial that has shown that in terms of survival, long-term survival, 30-day survival did not make a difference. But any small reduction in afterload, any small increase in coronary perfusion is definitely going to help the heart. This is what's called an ECMO pump. An ECMO pump is short for extracorporeal membrane oxygenation. It works like a cardiopulmonary bypass pump, but it is miniature, and you can hook it up to the patient's femoral artery and femoral vein, and the patient can go to the cardiac ICU without an issue. This is an Impella device. It's used by the interventional cardiology, our interventional cardiology colleagues a lot. We don't use it as much, although we can. And basically, it has it has a segment that's in the left ventricle and a segment in the aorta. So it takes out blood from the left ventricle and pushes it into the aorta. And it is one of the finest devices that can reduce the LV pressures. Once we're done with, once we have a patient on short-term mechanical circulatory support, we saw in the algorithm of the ESC guidelines, the patient can either recover, or if they are a candidate, they might have destination therapy. Destination therapy is basically a pump that is inserted. One end of it is in the LV apex, the other one into the aorta, but is a longer term. It could stay in for years. This is the older version, the HeartMate 2, and then there's the newer version, the HeartMate 3. So these are the options for mechanical circulatory support, short-term and long-term. To qualify, there's a revised Columbia screening scale. So if they score more than 5, then the operative mortality for the insertion of the HeartMate 2 or 3 is 46%. If it's less than 5, then the mortality rate goes down to 12%. And basically the components are mechanical ventilation, post-cardiotomy, prior LVAD insertion, CVP more than 16, prothrombin time more than 16. So in conclusion, CABG has a vital role in the treatment of the spectrum of acute MI. Surgical outcomes are highly influenced by patient presentation and comorbidities. Optimizing the timing of surgery is a key factor. Optimizing intraoperative and postoperative factors is vital to patient survival. Mechanical circulatory support is a good option as a temporary measure or as a destination therapy. I would like to thank you again for listening. I know I went a bit in detail with these devices, but I think it's very important to know about them. Thank you very much.
Thank you very much, Dr. Abdul Wahab. Very practical review of the subject, and I'm sure that there is a lot of benefit by all what you have said. The floor is now open for our panelists, all of us, for discussion, questions, and answers for if there is any question from the audience. I don't see any questions as far as the details that I have, but we can kickstart. Dr. Abdulaziz, what antithrombotic strategy you use for a patient with ST elevation MI with PCI?
Yeah. What is the strategy you mean? So we have had many patients with acute ST elevation MI, and our default strategy is primary PCI. Unless there are other problems, but yes, the default strategy is primary PCI, and try to achieve it in the shortest time as possible.
No, I'm talking about antithrombotic management.
Thrombotic, yes, sir. Talking about antiplatelet and antithrombotic therapy. So antiplatelets, we load all these patients with aspirin and a P2Y12 inhibitor. Most commonly, we use ticagrelor because that has been shown to have lesser resistant thrombosis rates. I know there's a recent head-to-head trial comparing clopidogrel and ticagrelor, but we still prefer ticagrelor. And antiplatelet therapy is usually unfractionated heparin, and that has been shown to be highly effective. And bivalirudin in high-risk patients but I don't know about the availability of that. So most often it is unfractionated heparin during the procedure, followed by low molecular weight heparins post-procedure.
Dr. Habib.
Please, Dr. Saeed.
Yeah, I would like very much to thank the presenters. All of them had a very elegant and comprehensive approach to the subject of acute myocardial infarction, either ST elevation or non-ST elevation, medically, interventionally, and surgically. So that was a nice roundabout. What I would like to highlight here is the importance of the condition in young patients, because we see that frequently. You know, in Salmonia we have many of the expats. Some of them are, the majority are coming from Southeast Asia, and majority of patients also be below the age of 55. So I would like just to highlight the possibility of non-ruptured plaque in these patients. You know, these patients may have tendency to have other conditions like what both Dr. Aziz and Dr. Amir mentioned, the thrombosis, the hypercoagulable state, especially with the era of the COVID-19, the vasospasm, the microcirculation abnormalities, the myocarditis. And so it's important that to keep in mind for all those who are concerned with the diagnosis of myocardial infarction is to keep in mind that there is a kind of like 11% of patients, especially those young in age, can have other causes than ruptured plaque. They have the vasospasm, they have the myocarditis, the stress myopathy, all what I've just mentioned now. So please keep in mind possible other diagnoses in this group of patients.
So to add to that, there's also a spontaneous coronary artery dissection that we see sometimes. And like you said, vasospasm is a frequent condition.
Yeah, particularly spontaneous coronary artery dissection could be more prevalent in females and particularly during pregnancy, this condition as well. Also, sometimes the influence of drug addictions, the cocaine and methamphetamine, these are also important contributing factors.
There's a whole new syndrome coined, which is called as the Minoka syndrome, the myocardial infarction with normal coronary arteries. And some of the causes are the ones that you have mentioned. And then there's also Takotsubo cardiomyopathy. And the recent updates have also pointed out towards the role of two things. One is angiography plus intravascular imaging. So an optical coherence tomography can show what is the pathology behind it, whether there was a plaque rupture or just thrombus or dissection, that can be seen. Also, there's a certain role for cardiac MRI. So cardiac MRI can also give a diagnosis. It can show us scars, it can show us hypertrophy, it can show us Takotsubo very well. And this has also been recommended as a modality of investigation in these patients who present with a myocardial infarction but have normal coronary arteries.
Okay, I have a question for Dr. Amr and Dr. Aziz, both of you. Any of you has the experience of using provocative tests for the induction of vasospasm in the Cath Lab, like we're using the acetylcholine or testing or?
Yeah, we have in our practice, we have a large women's health cardiology practice where we see a lot of patients with no epicardial disease, but with typical angina. And we do have a program of measuring CFR and doing provocative testing in our lab to document a clinical entity that is consistent with their syndrome. Now, the question becomes twofold. One is a little bit cynical, but these interventions and these evaluations are not well compensated in our healthcare environment. So it becomes problematic getting them funded and approved by insurance providers. And the second is, what do you do with their therapy? And the argument, I think, for their therapy is this one gives the patient a diagnosis that helps them understand what's wrong with them. And a lot of these patients are pawned off as being crazy or troublemakers. And if you can give them a diagnosis, you give them the confidence in understanding that there is something tangibly wrong that can be treated with the use of calcium channel blockers or long-acting nitrates. There is some data for the use of statins in these patients to reduce the inflammatory milieu as well. So I think that's the value in this clinical space in giving the patient a diagnosis and adjusting therapies accordingly.
Thank you.
My question for both Amr and Abdulaziz about inferior wall myocardial infarction, and if the patient arrive early, whether thrombolytic therapy would be an advantage, especially we have a poor population who cannot afford full investigation. And for Amr, in the COVID area, the same thing, inferior MI in the COVID era. I know that if the patient arrive in the morning, it is fine, but if it is arrive in the midnight and early arrival after maybe within half an hour of inferior MI, to mobilize the Cath Lab in a place where it is not open all the time, it is a bit costly. So if somebody arrive late, if somebody arrive early for what after inferior MI, within short period would you go for thrombolytic therapies?
Yeah, certainly there's data to suggest in these lower risk MIs that thrombolytic therapy may not be as disadvantageous. However, in our environment, our Cath Lab is open 24/7. The cost is not prohibitive, at least in our hospital where we have a mission to treat under or uninsured patients. So we do not tend to use thrombolytic therapy, especially now in the COVID era, actually, where our ICU resources are limited. Patients who receive thrombolytics require ICU admission for frequent neuro checks, whereas patients who receive high quality PCI who are clinically stable are managed on the ward and never enter the ICU. So that's certainly one of our considerations here at this time.
And Abdulaziz?
Dr. Amit, this is Dr. Rath here.
Yep.
Yeah, it was very nice presentation in this COVID acute MI management during COVID. We in India, we had a peak in first wave peak in September, October. Now we are coming down. We're waiting for some areas. Second peak has started. We had initial phase, first 2 to 3 months, like you all felt, that we felt as if cardiac MI, heart attack patients have disappeared. Subsequently, we realized that a lot of patients, actually, they were reluctant to come to hospital. They came late. Many patients died at home. And many patients who came late, they already had MI and they came with heart failure. And then, as you explained, same page we went through, they came acute MI when the pandemic was in peak. We had a lot of acute MI. We didn't know what to do. People are scared to touch these patients, so most of them went through initial thrombolysis. Subsequently, for last 3 to 4 months, they are being treated as primary angioplasty. But the problem is, again, the logistics problem. See, when the patient comes emergency, first thing, every patient acute, they want to rule out COVID. So they will do the test, takes 3 to 4 hours. By the time the time is lost. So what we did is, we decided that primary acute MI will offer primary angioplasty immediately. So what it was all these things, logistic was bypassed. We created a green channel where the patient comes, immediately WhatsApp message goes to the manager, the consultant cardiologist, the sister in charge. So immediately patient is shifted out with all precautions. Angioplasty was done. And then patient was kept in another separate room till the report comes. So that's how we did it. Another problem we saw during this endemic, COVID patients presenting with peripheral embolism. We had 2 patients who were about to lose their legs, large thrombus in the femoral artery and down there. So in those 2 cases, we aspirated with there's a called penumbra device. You can take it out and we saved these legs. And we had many patients, like you showed one pulmonary embolism, but most of the patients who had pulmonary embolism, massive pulmonary embolism, we lost. 2 patients we aspirated, we saved them. But this is bizarre presentation, patient coming with ST elevated MI, enzymes raised. We take them to the Cath Lab, normal coronaries. Many patients we saw only clots. No, we did the OCT 2 cases, only clots. No atheromas to plague. We just aspirated and patient became okay. So all this during this period, COVID period, we have seen coronary artery disease, coronary artery presenting in a different way. And all these things we learned, I think there should be a new guideline for management of patients with COVID during COVID era. It will come out in ACC guideline or something, but it will change. Definitely the guideline will change. We have learned a lot of things with this. Now, another thing is post-COVID sequelae. Like you told, a lot of patients are coming with arrhythmias, LV dysfunction, and this is the new wave of patients who are coming now. And very nicely, Ajit showed a very few cases where he has done primary angioplasty. Very nice to know that the BSH Apollo is providing this service. And this is really primary angioplasty is the treatment of choice for acute MI, the first treatment of choice. And if the facility is there, patient comes in time, that's the best. And surgically, role of surgery is very, very small now in acute MI. In probably patients who have, if they develop VST, large VST, or maybe non-ST elevated MI, if there's a critical left main clots and all these things, multivessel disease, those patients can go for surgery. But ST elevated MI, role of surgery is very limited. Most of the surgeons, they don't want to take it. Results is mortality is very high also with surgery. So non-surgical treatment with angioplasty stenting is the treatment for this ST elevated MI. And many times we were using this ECMO and impeller devices, IBP. These are support devices which Dr. Waib has very clearly told. I think it was a very nice symposium on acute MI, and all the speakers, they spoke very well, and there are a lot of things to learn, and it was very, very educative. Thank you very much.
Thank you, sir. I believe Dr. Najah has a question.
Yeah, I have a question. You said the rate of STEMI presentation has dropped. Has anybody looked at myocardial mortality figures during this period for people who could not reach a hospital or were afraid to come to hospital? Has any study been done, epidemiologic study in the States or in Europe, looking at rates of
no study has, yeah, that is a very good question. That's a very good question. It was observed throughout the world, from Wuhan to Europe to USA to India, that during that period, the patient coming to the hospital with acute MI drastically came down. The explanation is, first is probably people were staying at home and they were not going to work, less stress, less physical activities, less mental activities. And the other is, of course, people are scared to come, and many patients died at home. Some patients started coming late with heart failure, and when you take the history, they were, but I didn't see any publications on that.
What you were asking. Any publications from Europe or the United States? Any publications or data on the mortality figures?
Dr. Amir, can you answer?
Certainly can tell you about.
Yeah, it has been demonstrated that there's been an increase in STEMI mortality because of the changes in how we manage STEMI during this period. There's also epidemiologically, it's very difficult to assess the cause of mortality when patients die outside of the hospital, especially during COVID. But if you look at the excess mortality tables that have been provided by public health departments around the world, there's certainly extensive excess mortality that's been observed worldwide. And not all of this is COVID. You know, part of this is probably related to suboptimal or reductions in regular cardiovascular care because of COVID. You know, hashing this out and figuring out how to avoid this in future pandemics is going to be critical, as we expect this to be a recurring healthcare issue in a globalized world.
We have a couple of questions actually by the audience, so I better to ask this question. What is the role for statin to be used in ST elevation MI management, if there is any? So, Aziz,
yes, sir. The recommendations are to start off all these patients with the high dose statins because their risk during the acute MI and for future events. All these patients should be started on high intensity statins.
Okay, so high intensity statin is high risk. So does patient with a previous history of myocardial infarction and now on warfarin is at lower risk of getting hypercoagulability after coronary infarction? This is another from Zahra.
Yeah, I mean, certainly hypercoagulability and the comorbidities that are associated with hypercoagulability that result in the patient to be on warfarin increases the patient's risk of adverse events. We're lucky now to live in an era where there's very good data on the safety of single antiplatelet therapy with systemic anticoagulation with contemporary drug-eluting stents. Early in our stent experience, these patients were treated with dual antiplatelet therapy, aspirin, clopidogrel plus warfarin, and had a very high burden of highly morbid bleeding complications. And now we're able to avoid that by being informed by good clinical trial science and improved stenting quality.
All right, and this is for you, Amr, also. If you have any myocarditis, pericarditis previously, are you more vulnerable to contracting it second time after COVID-19?
That's a great question. The myocarditis narrative in COVID-19 has been highly controversial and was fueled by a study in Germany where a non-randomized sample of patients received cardiac MRIs and they reported a high incidence of myocarditis. That study received a lot of criticism because the mechanism of selecting those patients was not rigorous and the findings were non-specific, and in fact have been replicated in other non-COVID viral infections and have not been shown to be associated with long-term adverse events. So the story on myocarditis and COVID, I don't think is completely written yet, and will certainly be an area of interesting investigation in the coming months and years.
And this is also for you, Amr. Any gender differences in cardiovascular events among a COVID-19 patient as per your experience?
I'm not aware of anybody, but perhaps the panelists may have made other observations.
And this is probably Dr. Saeed can answer. What is the quickest route for high-risk patient presented with an event that you will advise in Bahrain, considering the busy emergency room?
As you know, at some time in the beginning of the crisis of the COVID, there was quite a significant limitation of referring patients for primary PCI, and most of the patients were subjected to a fibrinolysis strategy. And with the reactivation of the invasive lab in Mohammed bin Khalifa bin Salman Al Khalifa, we started to refer again patients for interventions. So I can say that we observed a difference in the outcome because we didn't have much of a choice. We had to depend on the fibrinolysis alone on the beginning, and we didn't meet that much of cases that needed urgent intervention. So at that time, the strategy was acceptable, with acceptable outcomes on overall.
I must say also that Bahrain Specialist Hospital and Apollo Cardiac Center, they have done quite well during this epidemic with some patients who require intervention, thanks to that service has been provided.
That's it. Yeah, our strategy has been to do primary PCI, and we have seen a lot of patients who were thrombolized in Salmania and then later on presented to us with post-infarction angina, and then when we had a look at their angiograms, a lot of them had underlying critical lesions and needed angioplasty as well. So the strategy of thrombolysis is good, but then also it should be followed by invasive angiography as per the guidelines.
For Abdul Wahab patient who has a post-MI VSD, what strategy you have for management? Do you take them early, or you support them and then do the surgery after stabilization? As you know, the mortality is very high if you take them early.
Yeah, thank you very much, Dr. Habib, for this great question. This issue is actually very controversial, and the reason is that a lot of the data is retrospective, and the patient populations are very low to make definitive decisions. But the bottom line is the hemodynamic stability of the patient. So patients who are stable enough to to wait for surgery are probably better off waiting for 5-6 days until all the fibrous tissue has formed within the myocardium, so that we can put a patch easily without anything, without any of the myocardium tearing. But if patients can't wait that much, then we're forced to take the patient for higher risk surgery.
Actually, Dr. Habib, you have a very telepathic power, taking the exact question out of my brain and put it to Dr. Abdul Wahab, because that point I was going to ask him, because in my experience where I've been trained in the Netherlands, the outcome of early intervention, usually in repairing VSD complicating myocardial infarction, was the outcome usually very bad, and the mortality is very high. And we do all the possible means of stabilizing the patient to give a chance, as Dr. Abdul Wahab said, for some fibrotic tissue so he can put his patch and secure it in place. So that was one question I was going to ask him.
Thank you.
I would like to ask one question to Dr. Amar. What is the strategy?
I'm sorry, I couldn't hear the question.
Can you unmute yourself?
Yeah. So my question is to Dr. Amar. Okay. So I'll repeat my question. My question is to Dr. Amar. How do we select the anticoagulation and antiplatelets when patient get an acute MI and also an arrhythmia like an atrial flutter? So what is the strategy? Like, do we keep the dual antiplatelets and the anticoagulation together? Or do we go with the Hasbled score and then choose between the dual antiplatelets and an anticoagulation?
Yeah, I think this is a really important question and has been critical in our practice here, given the large number of patients that we treat who are anticoagulated. Our practice is to treat with systemic anticoagulation and single antiplatelet therapy. So patients usually receive apixaban and clopidogrel or ticagrelor. We maintain aspirin therapy during the duration of the initial hospitalization, but we do not discharge on triple therapy. And that's been shown to be a safe and effective strategy now in multiple clinical trials. I think the critical part of that too is having high quality PCI at the time of the index procedure, making sure that the stents are well sized, well opposed, consideration of the use of intravascular imaging to confirm that the quality of PCI was excellent. Is also part of that equation.
I have a question for Dr. Abdulaziz with oxygen therapy for myocardial infarction. I know this came from the recommendation, but if you remember in our basic knowledge of oxygen and oxygen hemoglobin dissociation curve, you remember the curve that the number 95 is the magic number. Anything that goes below 95, the amount of oxygen available to the tissue will be low. So why this 90% comes from?
This comes from 3 trials basically. So this come from 3 trials basically, and all these trials have shown that patients who are breathing room air and able to maintain a saturation of 90%, they have done well. I mean, you talk about the oxygen dissociation curve, but there's also the theory of oxygen radicals. When you give supplemental oxygen to these patients, oxygen-free radicals are created in the circulation, and then they can cause more myocardial injury. And this has been well demonstrated, and this guideline has come across in most of the guidelines now, where oxygen only if saturation is less than 90% or a PaO2 less than 60%.
So Professor Saeed, you don't put your patients on oxygen?
Actually, this is my everyday fight in the ER or in the chronic care. You know, everybody, as you said, used to, a patient comes, before they measure the saturation or anything, just put the oxygen, and I tried to explain for them the theory of the harmful oxygen radicals, and I try to explain for them that this is a treatment. Oxygen is not a supplement, it's a treatment, and it is exactly like morphia, like aspirin, like anticoagulation. It has an indication and it has a contraindication. So this is the everyday problem with everybody, doctors, nursing, staff. Just please do not use supplemental oxygen if the saturation is above 90%, because that can harm the myocardium.
Amar, you observed the same thing also? 90%.
Yeah, this is a chronic fight, sort of all over the place, and trying to be evidence-based. Sometimes you have to pick your battles, and this is a tough one.
If you don't mind, Dr. Habib, I would like just to mention one thing. I'm sure lots of you have been aware of the press release from the National Health Regulatory Authority approving the emergency use of Pfizer COVID-19 vaccine in Bahrain. So for who have not heard about it, this was approved yesterday as an emergency use for indicated for patients that will be identified later on. The information will be released later on, but Bahrain is the second country after the UK to approve emergency use of the COVID-19. So hopefully this will be the first, and probably there will be other vaccines that will be approved very soon. Hopefully that will be also something to look forward for, because we do have a special reason to finalize the vaccinations, because we'd like to see family members very soon after they receive the vaccine.
Yet again, another example of Bahrain leading and us being behind here in the US.
So
no, I think in Bahrain, I think it's just fair to say that the COVID was tackled absolutely fantastic way.
Sure.
Compared to many areas. So I think it's part of all the situation taken by the high authority and executed in fantastic way. So
that's very true.
Has anybody seen small bowel ischemia or large bowel ischemia with the COVID? A thrombosis, many case reports came in the GI literature actually of vascular thrombosis in the gut. Has anybody seen it among the group? There is even a case of bowel transplant post-COVID reported from India, actually from India, in a child who had complete loss of bowel due to superior and inferior mesenteric thrombosis.
Well, thrombosis, I think it is diffuse all over the place. So I'm not sure whether it occurs in Bahrain. If Abdul Wahab agree, I think we treated some of the patients with ECMO for COVID patients. I don't know. I think there is one patient, if I don't mistake. I think there might be one patient in Bahrain, but I can't be absolutely sure. But maybe there is one here.
I can't specifically recall a small or large bowel ischemia per se. But I mean, Dr. Amr illustrated quite elegantly the hypercoagulable status of these patients.
I think the probably most of the ischemia that we're seeing in the gut related to COVID are related to patients who are floridly septic on multiple pressors, who have secondary bowel injury due to watershed effect. I've not had primary thrombotic mesenteric ischemia, at least in my experience. I'm sure it's occurred, and I'm sure it's something that's been reported.
Yeah.
Great. Any more questions? I don't, maybe.
I have a question also about the protocol of anticoagulants given to COVID patients. When do you start anticoagulants? What evidence do you need before starting systemic anticoagulants? When do you avoid, when do you use anticoagulants in COVID cases? So what are the criteria you're going to look for? Not in a patient necessarily presenting with a coronary event, but in patient who comes in very sick with COVID, when do you decide this is the time to start anticoagulants?
So there's no clear guideline on this yet. This is an area of intense research currently. I know that there are different hospitals with different guidelines, and some places have used a strategy of routine screening for DVTs in patients admitted with high-risk COVID, either with ultrasound or with frequent checking of D-dimer. And once they are either identified as having a lower extremity DVT event or having a D-dimer above a certain threshold, they get treated with systemic anticoagulation uniformly. There are other strategies where patients are risk stratified clinically based on their risk factors, and they're triaged in that way to either prophylactic dosing of anticoagulation or upfront systemic anticoagulation. The unanswered question is the long-term need for these therapies. So how long after your index hospitalization should you be treated with anticoagulation? What are the safety implications for this? Because as you know, the bleeding complications are not benign. And then finally, is anticoagulation or antiplatelet therapy more important? And this is, again, an unanswered question. We know that there's increased platelet reactivity in these patients, and we know there's a true thrombotic dysregulation in these patients. So finding that answer is an area of intense study, and I think we'll learn more in the coming few weeks and months.
But most of the people, most of the centers, they use if the D-dimer is more than 2 times. And duration is definitely during the hospital stay, but many patients are recommended to continue it for 6 weeks after discharge, total duration. But it's all individual centers' decision, varies. There is no general recommendation. But now, and most of the patients who are admitted in ICU, they are put on anticoagulation during the hospital stay.
There are 2 more questions here. Does a thrombolytic agent result in cardiac arrest post-administration? It looked like a general question. Thrombolytic agent causing cardiac arrest.
I think there's no straightforward answer. I mean, the problems that could happen with thrombolytic therapy can cause it. So there can be an anaphylactic reaction, which used to happen quite often when we used to use streptokinase. But I think most of the centers have shifted to fibrin-specific agents now, and we don't see that often. There are also revascularization arrhythmias that we see sometimes. Sometimes we see patients going into heart blocks and VTVF, very rarely. But as such, I don't think the thrombolytic is involved in that.
The other question is, again, for Amr. What is the prevalence of arrhythmia and conduction system disease in patients with COVID-19?
Yeah, it's quite prevalent, actually. So as high as 25% of patients with hospitalized with COVID will have an arrhythmic event. Now, most of those, thankfully, are SVTs, whether they're sinus tachycardia, AVNRTs, or AFib type supraventricular tachycardias. However, in those patients admitted to the ICU, the incidence of VTVF is quite high at 6%. So understanding that there's a risk of serious arrhythmic complications in these patients is critical in their management.
Okay, role of ferritin. This one, I don't think it's related to the subject here, but somebody asked role of ferritin in diagnosis of COVID-19. So do you have any information for us?
Ferritin is the marker for diagnosis. One of the marker, I think.
Used as a marker of inflammation in COVID, but not as a direct diagnostic feature. People use D-dimers, ferritin, interleukins. All these things are measured as a marker of inflammation.
I mean, in these patients who are critically ill, the presence of a high ferritin probably tells you that the lab is open and doing their job, right? I mean, it's a given that they're going to have a high ferritin. I'm not sure how specific the finding is.
All right. I think that's all the question that we have here. And anything, Professor Saeed, do you want to say anything?
I just enjoyed the discussion. It was very rich in information from every party. All the participants had quite good good deal of information and very comprehensive approach. So it was my pleasure and honor to be part of this activity. And thank you all for that.
Dr. Rath, you want to say anything?
Yeah, very educative. I really enjoyed it. And thank you all.
Prashant, what is Prashant? Did you want to say anything?
I would like to conclude as a vote of thanks. It is a well-known fact that the management of an acute myocardial infarction is a medical emergency. This webinar covered a broad spectrum in the field of acute myocardial infarction and its management, and from prevention to interventional, specifically in COVID-19. In the beginning, I would like to thank our chairperson and chief guest, Dr. Habib Al-Tarif, who is a consultant cardiothoracic surgeon and vascular surgeon at Mohammed bin Khalifa bin Salman Al Khalifa Specialist Cardiac Center at Bahrain, for kindly accepting our invitation and gracing the welcome speech. I'm also thankful to Dr. Abdul Aziz, who's an intervention cardiologist and director of Cath Lab at Bahrain Specialist Hospital, for updating us with the recent trends in the management and strategies for acute myocardial infarction. I would like to express my heartfelt gratitude to Dr. Amer Ardati, who is an intervention cardiologist, director of Heart Center at University of Illinois, Chicago, USA. Dr. Ardati has very effectively highlighted the cardiovascular manifestations of COVID-19 in patients presenting with acute myocardial infarction. I would like to also a sincere thanks to Dr. Abdul Wahab Mohammed Al Khalifa, who is a consultant cardiac surgeon at Mohammed bin Khalifa bin Salman Al Khalifa Specialist Center at Bahrain, who throw the light on paramount role of CABG in acute MI. It's a privilege and great joy for me to extend a word of thanks to our distinguished panelist, Professor Al-Said Mohammed Al-Said, who is a consultant cardiologist, head of cardiology department, Salmania Medical Complex, and Dr. P. Sirath, who is an interventional cardiologist, head of Heart Institute at Apollo Heart Institute, Hyderabad, and India, to share their expertise in the concerned field. And an event like of this dimension cannot happen overnight. It requires a meticulous planning and execution and eye for detail. I take this opportunity to extend my most sincere thanks to Dr. Naja Rashid Al-Zayani, who is a vice chairman, and Dr. Qasim Ardati, who is the managing director of Bahrain Specialist Hospital and BSH Apollo Heart Center, for the successful event. Finally, a big thank to you all for being with us this evening. It's been a great pleasure.